invitation and thank you for your friendship. So, this is the hospital I work in close to Venice. So, arthroscopic and open bunker. There's an open issue to the open bunker, but the ultimate predictor of success is after the treatment is the activity modification. So the recurrence can be because of the type of the sport, and there are variables. So collision and contact sports are at risk for recurrences. And we have patients that get elder and they want to continue doing sports. And so we have to manage recurrences in elder people as well. This is an inferior labrum lesion, and this is the treatment that is almost all the time performed. So most of the surgeons they treat just the anterior lesion in the anterior instability, either if they do it arthroscopically or open. But keep in mind, take home message, we have to hold the trousers, the loose trousers, by two hands, not just by one. And so we have to reduce the axilla volume. The posterolateral portal is crucial to place a device, an anchor at heart 6, in order to have that shift closing, reducing the axillary volume. And this is what I, as a rule, do. You can operate by an open procedure and do the capsular shift. So as for folding in a double-breasted paletot and doing the treatment of the labrum as well. This for young people when you cannot do Latarjet so easily. And by the arthroscopic way, you are not so efficient. So this is a patient with a recurrence that had a hag lesion, humeral avulsion. This is difficult to find by plastic imaging and difficult to treat. This is one of several ways to treat it. And some patient has no recurrences but has pain. And we should question, is this pain due to supraequatorial lesions? This could give an answer to some of the patients that do a Latarjet procedure that they are symptomatic even if stable. So we right now learned how to treat the Hill-Sachs lesion. I wrote in this magazine, Italian magazine, 2005, the Hill-Sachs and the risk of a medial Hill-Sachs. But better, Yamamoto and Ishii Itoi, they described in 2007 the glenoid tract. This is my friend Ishii Itoi, and the off track. And this is an off-track bipolar lesion at the humeral side and at the glenoid side. And about it, the glenoid tract, my close friend Giovanni Di Giacomo, an Italian guy, is continuing studying and writing about. How to plane, CT scan is mandatory in the recurrences. And the glenoid bone deficiency is better treated by grafting or by Latarjet, but you can also treat with some bone block. I'm not so sure that the bone block is enough, This is what I start doing 2005. But you can have recurrences because the patient has another trauma, another efficient trauma, and you have both at the back and at the front, so anterior and posterior lesions. As in this case, there can be another problem. This is a posterior bone block, and the patient has a subscapularis lesion, a subscapularis tor, and there is a static anterior subluxation. This is another case we know there is a screw possibly with a resorption in the posterior subluxation. So there is a posterior problem, and the reversible sacs is in. So I want to show you some about the anchors. Some of the anchors are so medialized, and this medialization, in the past we saw many of these, this can lead to the insufficiency of the ligament and capsule. And you have to revise the patient. But in the past, we had hard anchors, and another message, we should not anymore use hard anchors. They can be mobilized and can lead to arthritis. So this patient is not is an arthritic patient, young and arthritic. So when we revise shoulder for instability, we have to remove loose devices, staples. And when you have to remove anchors or any device, you will have a glenoid joint insufficiency. So there's a bone insufficiency when you revise these patients. And this, so sometimes the patient will not anymore redislocate. But this is a devil device that a shoulder surgeon used for this patient. But what to do? And you will be in trouble when you will have to do arthroplasty. And this is a young man, this very, very young boy. The cartilages are open, and this is what the surgeon does. So no more these locations, but early arthritis. Several few cases. This is a paratrooper of Folgore parachute. So he had no trauma, and labrum detachment, a bunker lesion. And the surgeon, he treated the bunker with 3 anchors, and this is what happened after. So the stress riser effect of the anchors, and I had to revise to a Latarjet. Latarjet is a safe procedure. Yes, if you are a nice surgeon, experienced surgeon, but there is a learning curve, and you can have problems. The stripped subscapularis can be another cause of recurrences. So the humeral head dislocates and strips the subscapularis off from the glenoid neck. And you have to restore in order to restore the stability, to refix the subscapularis. ISIS score. Pascal Boileau described this comparing the Latarjet with the gold standard procedure. But is the golden standard what he described? The patients were operated by him between 1998 to 2001 by just resorbable screws and resorbable sutures, and so they had a high revision rate. In 2011, I started doing arthro-latarjet as taught by Laurent Lafosse. These are my first experiences, but I want to show you some failures. This is a latarjet failure. We have to deal with loose bodies or to withdraw anchors, and we can use grafts for to augment the glenoid. And then the distal capsule, if any remaining, for to re-establish the stability. This is a latarjet and failed latarjet and revision. We have to take the plate off and screws, and this is what we do. We do a remplissage and then a bone block. This is my worst case. This is from mine. The patient was a climber, and he had many dislocations. He came to me with this underestimated bone loss from me. I did an arthroscopic latarjet. Look at the graft is medial, and he had, this is the post-operative, the next day CT scan, and humeral head is subluxating anteriorly. I did a revision the next week. This is a remplissage with 3 anchors, but not enough to maintain the humerus stable, and is subluxating anteriorly. And I had to fix the subscapularis closer to the articular edge, and this gives the humerus recentered. This the patient, this the X-rays after. Then posterior instability and recurrence. This is the case of a male, 22 years old. He had 3 previous surgery. So one arthroscopic stabilization, the second iliac crest graft, and then I did opposite iliac crest graft, labrum reconstruction with the tibialis anterior tendon, and the infraspinatus lowering with the remaining of the labrum graft. These surgeries are not that easy. The best, the more skilled arthroscopic surgeon we have, Laurent Lafosse, did this in Nancy. And you see that there's some suboptimal results. Care, don't go to the OR so easy. These are my friends, these are the surgeons of my new group. We have fun together. I'm so happy, even if I am retired, so happy working with them. Thank you.
Thank you both, Enrico. It's our pleasure to introduce Prof. Lish from Brazil.